Welcome to InnerSight, Health Optimization with Rudy and Sean.
Here we go, Sean, podcast number 30. Who would have said, 30 weeks later. So interesting.
Time flies.
Yeah, it does, and we're almost in December. So here we go. We see in our screenings at InnerSight that we use fitness as a proxy for quite a lot of things, how you're going to live long. And with that, we test muscle. And in muscle, we have to be carried by bones.
Yes, and also when we talk about longevity, there's certain things that can cut that journey short. And one of the things is a hip fracture.
Absolutely.
And we're going to talk about that a little bit as well. And we've mentioned it in a previous podcast as well. And that's why we've got the specialist here today, so that we can talk about something called osteoporosis and bone health.
Yeah, so we've got friend, colleague for the last 12, 13 years from Mediclinic Leipold. He's also moved a little bit in his practice. So Dr. Marius Roos. And Marius, I'll maybe let you tell your journey, how you've become a specialist in our silent disease called osteoporosis that we're going to discuss today.
Lovely. Thank you, Sean, and thank you, Rudy. It's really a privilege to be here today. I appreciate that. And I'm also amazed, and thank you for choosing this topic. I think it's such an important topic, and we're going to try to package and balance the information today for our listeners and audience. So my journey started, let's start as a physician. Then about 2015, I was invited to join the Osteoporosis Institute at Louis Leipold. And we went through a tough time in COVID years. And then at the end of COVID, near the end of COVID, the partnership sort of dissolved, and I felt like I still had a passion for bone health and osteoporosis. And I took the institute further. But since then, we sort of invested quite a bit in upscaling the service that we give. And so that's where we are today, sort of a unit that does not only do like bone mineral density scans, but really try to support people who want to learn more or have issues and challenges with their bone health, not necessarily even at, the level of osteoporosis, but earlier upstream, and they want to attend to their bone health, just to guide them. And so that's where we have started to create this holistic approach, and try to educate wide. And that's one of the reasons why I'm excited about it, that spread the message, because I think the one thing, the partnership of bone and muscle is, to me, when I look at the science, becomes such a central part of longevity and a healthy lifestyle. It's such a foundational part of that. And so investing in that is really crucial, and getting that message out, to people, what your bones and muscles actually mean to you and to your health overall. And we are really privileged at the era that we live with the gift of science. It's been tremendous. And I think we want to really package that information in a balanced way. That's really important. And I think my functional medicine qualification and experience also helps a lot in terms of bringing balance to this whole discussion. And so, that's what I do.
And I think that's exactly how we got here, because when we screen people, we see this shift in hormonal. People we like to say, for us to screen people, we would like to catch them at 35. We see a big shift in physiological changes at 35. Mm. But what we've also realized is it's almost like having money in a bank account. It starts rolling forward if you look after it. But if you don't, it's like having debt in the bank account. It rolls backwards on you very quickly. So what I'm trying to say is, we actually came to the topic through the things that we screen, because we don't really screen for osteoporosis. So maybe just take us to say, what is osteoporosis?
Yes, but I also, part of the problem is that it's such a silent disease.
Yes.
You don't know you've got the problem
Yes.
until you break something.
Yes.
But yes, please carry on.
Yeah, just how do the people outside understand osteoporosis? Because even, I mean, me reading for this podcast, I learned a lot, but maybe just how should we think about it?
I think if we want to try to understand osteoporosis, we have to step back a little bit and try to understand what is bone, healthy bone in the first place. And then that structure helps us a lot. So, I mean, bone is more than just the scaffolding that holds our muscles and other organs together. It's more than like sticks or bricks. It's indeed living tissue that are metabolically very, very active. And we know, I mean, it's about 60% of bone usually consists of a inorganic matter, minerals that forms the strength. It's like the cement that keep things together. But then there's a 40% organic tissue. Most of that, 90% of that part is collagen, and then other proteins. And then surprisingly is living cells that is part of this thing that regulates the internal homeostasis of bones, building bone, breaking bone down. We can talk about that maybe later, but just a basic understanding of this and understanding the function of each of these cells and the composition has been really led to the advances in our management and also diagnostics. And to understand that help us to interpret, for example, the bone scan, what is the exact value of a DEXA, in this whole construction, if you understand how bones is constructed. But then I think a lot of the advances has been in understanding of the crosstalk between bone and other organs. It's not an isolated structure, the crosstalk with muscle, for example. So via certain chemicals and proteins, and also those proteins speak to the immune system, they speak to our metabolism, they communicate, our messengers communicating to our brain and different organs. Osteocalcin, for example, is one of the ones that I've seen quite the best studied so far. But that crosstalk, also the myokines by muscle cells and how they communicate with the bone is actually fascinating. And I think that might in the future actually revolutionize how we see bone and so on. And then so in a way we can say it has endocrine functions because of its effect on metabolism, on insulin, cardiovascular health, but also the immune system is a big player here. So it is a strong connection, and the whole field of osteoimmunology is really growing. So when we look at bone and understanding its normal function, we need to consider, bone is actually much more than just bricks that hold us together. And so when we move then to understanding what is osteoporosis, so the first definition of osteoporosis was published in 1993 already. And I think that definition is really valuable. In that definition, we find also a lot of principles that guide us in, how do we manage it going forward. So, but basically what it is a chronic skeletal condition that is systemic, and it is also the two main components is a loss in bone mass and also a loss in the microarchitecture, so a deterioration in the microarchitecture leading to a loss in bone strength. And then susceptibility to fragility fractures. But
Okay, so sorry, Marius, I just want to stop you there. So if I had to say it to my daughter in high school, what would I say? I want to take it back to our layman listeners, because we've got our colleagues and we've got our layman listeners. So I want our layman listeners to catch up and say, it is, how would we say that? It's
osteoporosis is basically a loss in strength of bone, making them susceptible to break under forces, even relatively normal forces that they're not supposed to break usually. I think that's the easiest to understand.
Okay, so that's the high school definition, and so again, coming back to our colleagues, we need to think, okay, but this bone is broken or can break. So how do we think about that? Is it do we start screening early? How do we think about osteoporosis? Because I mean, it's too late if you have a hip fracture. So how do we bring it back to say, okay, but the diagnosis? Well,
yeah. So first of all, with the osteoporosis, it's a process where we lose mass. So in the beginning phase, when we grow and we become adults, we build up the bone and we build up our reserves. So at what age, more or less, have we reached our potential? In our 20s, 30s?
Yeah. So understanding the lifetime changes that happen to bone mass is very important. So so bone growth up to between 20 and 30, roughly, you reach your peak bone mass in that time era, and then usually it remains stable until roughly 50. And in men, there is a slow, gentle decline going forward, but in women we see a sudden, more rapid decline in mineral density, roughly at menopause.
So we should actually speak to the children as well, because if we reach our potential at 30, then it is so important to be active in that late teens, early 20s to build as much bone reserve as possible.
Absolutely. That is a critical point. So focusing on that, reaching our maximum genetic potential is really, really crucial, because what you have then is what you will have for the rest of your life. Then after that is literally preserving that. But that is a really key point that you make.
Yeah, so in a matter of fact, you can almost at an early stage, as early as 30, if you pick up signs or symptoms or lifestyle through a questionnaire, we might be at risk of developing osteoporosis later in life.
Wow. Okay, and then I'm going to come back. So we've topped off at 30, let's say at 30, and then how do we identify the people that we need to go screen? I mean, in my mind, I've got an idea, but how do you guys that work with this every day, who are the guys that need screening early? And who needs it 50 and who needs it 60? How do we get to know to keep people away from that hip fracture? Because I think for the layman out there, we have to say again, why are we doing this? Because a hip fracture, we've had Dr. Henny here that spoke about the hips, and he said, like, you have a 1 in 3 chance of dying from a hip fracture within the first 3 years of having a osteoporotic hip fracture. And so that is what we're trying to get away from.
And even with that, even those that survive, 50% of those people will never get back to baseline where they used to be. So your function in doing basic activities of daily life might be impaired quite a bit. So it is important. I agree 100%.
Yeah. Well, so the answer to your question has 2 parts. So the first part, we have to look at what the guideline says of organizations, IOF and NOFSA and so on. And then there's another leg, and that is the longevity approach, where we want to maybe look a little bit different at that doesn't sort of intervene upstream. But so getting clarity on what the guidelines says. And those guidelines are really solid, woven in science and evidence. And I think they remain the basis of who to screen. So firstly, the guideline says when you're 65 or older. So that is a clear indication for screening. When you are younger, and that is after 50, you need additional risk factors to be a reason for screening. And before 50, we look actually at osteoporosis a little bit different, understanding it different, because we're not sure how DEXA applies there, the testing, the bone scan, which we use as a screening, how to interpret the result in the young adult. And that is still needs to define. The definition of osteoporosis in a young adult is still not clear. So, and how to apply the DEXA scan. So that's where there is caution in doing that earlier. But the indications also says if you're a young adult, that means between, say, 20 and 50 in that time range. If you have other major risk factors that could be a secondary cause, a health condition that could be a risk factor, you may do a screening bone scan there. Obviously, if you break a fracture in that age range, you should definitely do that, because that is abnormal, a fragility fracture, obviously. But you need another clinical risk factor that is a significant risk for you to develop osteoporosis to do screening.
So for the layman, again, I want to take it back. If you are male or female, over 65, and you haven't had a DEXA scan, you should.
Definitely.
Yeah. Okay. So we've cleared that. We know now people after 65 needs a DEXA scan.
Yeah.
Maybe while we talk about the DEXA scan, maybe just tell people what that is, because we've had Dr. Hofmeyer here that spoke about the DEXA before and CT, and so he gave us the numbers of how much radiation there is, but maybe just tell us what it looks like if you go for a DEXA scan while we're at it. Have you got a scan in your room? Do you need to go to a radiology? How does that system work?
Yeah, so it's a radiation device. There are units, they're like bone units that does it, but also many radiology departments also have that service. So it's basically a bed that you lie on, and there's radiation, a radiation head at the bottom and at the receiver on the top. And so there are two beams, and that's why it's called dual energy. One measures the transmission of that radiation through the bone, the other one through the soft tissue, and then there's a calculation that happens to measure the difference and determine the mineral density of bone. And the radiation is extremely low. That's one of the benefits of that.
Yeah. So it's a low dose X-ray type.
Exactly.
Yeah.
Exactly.
And yeah, just to put people's mind at ease. So living by the sea, you will have about one in 3,000 of the amount that you would have as a yearly radiation at sea level. So that's about 3,000. So you will have 1 to 2 of these. I think it's microsieverts or something. I think but it is extremely low.
Indeed.
I mean, it's 100th of a chest X-ray. So it's very, very low. Okay, so we said 65 DEXA scan. Definite.
Yeah. A question on that. So if I'm 65 and I get my DEXA scan, I'm going to get a result. The result might be normal, or the result might show that I've got an issue. If I do have a normal DEXA screen, what would you suggest the patient then? Would you suggest they come back in 3 years, 5 years, 10 years? What's the guide more or less on that? Versus someone that obviously, if you've picked up something, you'll either intervene or do an earlier scan. But if you've got a normal scan at 65, do you need to go for a yearly scan then, or what's the opinion on that?
Excellent question. It depends again on your risk factors. I think it's important. If you have no clinical risk factors, usually the guideline says 3 to 5 years. If you have significant clinical risk factors and you are lucky to have a normal bone mineral density scan, you would like to monitor it closely. And I think what is very important then is to look at the rate of decline. And so the minimum would be a 1 year follow-up. If you have a normal bone mineral density scan, 2 years would be a reasonable time for a follow-up if there are clinical risk factors. And it depends absolutely on your FRAX risk score, and those type of other indicators of fracture risk would determine that interval, but it's between 1 to 5 years.
Okay, excellent.
Okay, I think that brings us to the patients we see the most, or clients, that 50 to 65. We see them younger, but we've now realized that's probably not the people we're going to really screen. So let's say that 50 to 65. If you're in that age group, who should think about that they might need a DEXA scan? So what would be the risk factor, or the main, let's say, 5 risk factors for someone in that age group to need a DEXA?
An important risk factor is family history. It has a really strong influence on your bone health. So genetics play a major role. So if there's a family history, that would be a really important one. Metabolic diseases are really common. So if you have diabetes, type 1 or type 2, it is definitely an important risk factor to bring into this equation. And then other autoimmune diseases, especially like rheumatoid arthritis, is really a major risk factor. Any other neurological conditions like patients with Parkinson's disease, or poor mobility after strokes, or muscular conditions, should be included in this equation. Inflammatory conditions, gut diseases, inflammatory bowel disease, celiac disease, malabsorption conditions. And then I think very important is patients with special dietary preferences, and especially vegans and vegetarian patients, because there are important gaps in their diet that puts them really at risk for poor bone health. So there's actually a very long list of health conditions. I think the other one that I just want to mention also is medication. There are quite a number of medication that can play a role. PPIs, the proton pump inhibitors, anti-acid medication, there's a definite link with poor bone health with that now. SSRIs, the antidepressants, there's a strong link. Chronic opiate use has been strongly linked with that. And obviously any patient who fall easily due to whatever reason, because I think falls is part of the package of risk factors. So those are a few important ones.
Wow.
Does it count if you fall off the bicycle?
Yeah. So, I mean, it's, but it does count the bicycle, because you fall and break. And my question then, in that same breath, is, I mean, we haven't really said, but it's not only a female disease. It is men and women. So for the price, because it's actually quite a cheap exercise. It doesn't cost like 10,000 Rand to do a DEXA scan.
Indeed.
So if you have an inkling that you might have osteoporosis, it might be a cheap exercise to just get a value.
That brings me to the other part of this conversation, the longevity approach. I personally think there's definitely value in that, and it's great to see that some expert like Peter Tia is really trying to add science to that approach, where we actually go beyond the current strict guidelines by the conventional way. And I think it is valuable for especially for to get a baseline for any female entering into the menopause. It's really valuable. But I would say even for men, and to be honest, I did my bone mineral density scan earlier this year, just to and it was, I think it might serve as an example how that changed my perspective on my bone health. I didn't expect. I was quite active throughout my life and healthy. I had one incident as at the age of 19, I had a cancer, and I got quite intense chemotherapy for a while, but was fully recovered in remission. So that's the only thing, and I never thought of checking my bone health, and I was surprised to see that both hips I fall actually. I'm past 50, so if you look at that criteria, I can use the T-scores in the low bone mass category. If I look at my Z-scores, it's actually a half standard deviation below my peers. So that might not seem significant, but to me it was really a wake-up call, considering I'm early 50s, and it was really a strong motivator in shifting my focus in implementing activities and lifestyle implementation and interventions to really support my bone health better. So I think really, as you said, it's a cheap and it's a safe screening test. And I think from that perspective and looking at that model, there is really value in having that approach.
And listening to, when you mentioned all the risk factors and you think of someone in their 50s, I mean, how many people use SSRIs or PPIs, or, I mean, the list goes on. So it's unlikely that you find a lot of people that's not on one of those medications or does not have one of the other risk factors.
It is.
Let's just touch on the subject, but medical aids. I suppose the issue comes in that how easy is it to motivate for someone over 65 to get a DEXA? And then how easy is it to motivate for someone between 50 and 65? It's not something that we do because we don't really work with medical aids, but I mean, a big part of the population, that's the first question you get. Will the medical aid pay for this?
So after 65, fairly well. It's quite well reimbursed, I must say. Before that, it's like very difficult. Here and there, with motivation, you might be successful. But in general, it is poorly reimbursed out of the standard times of indications for screening, unfortunately.
But fortunately, it's not that expensive.
Yes.
Or maybe just pull us back to the scan. So for our colleagues out there, so just to think about a T value. So a T value is pretty much a 0 T value is the standard of a lady at 30, if I understand it correctly.
Well, gender wise, if you're a lady compared to a lady of that age
so
group.
We compare it. So the reference is the NHANES reference database. It's Caucasian female between 20 and 30, healthy female. Okay. So even if you are a male, we compare yourself with the men with that reference range. And it turns out to be a good comparison, even for men.
Okay.
So as a baseline for normal.
And that would be 0.
So the average there would be a T-score of 0.
Yes. And then as you now progress lower, you get a minus.
You get a minus.
Okay.
Yes.
And you will then, can you diagnose on a T-score, let's say you get a T-score of minus 2.5, you will diagnose osteoporosis, or do you need anything else, or how do you think about a DEXA scan when it lies on the results lie on your desk?
Yeah. So the diagnosis of osteoporosis, if you have a fragility fracture, even if with a normal T-score, you have osteoporosis. So that is one part of the diagnosis. If you look only at the T-scores, a T-score, as you said, below minus 2.5 is per definition, according to the WHO criteria, osteoporosis.
Okay, and then that piece in between where you probably now fall, you definitely lower than the 30-year-old, but you're definitely not at a minus 2.5, but you're now trickling. So my where I'm leading with this question is, can you go back up, or can you just sustain, or is it always a trickle?
No, you can definitely improve that.
Okay.
I must say, I have seen phenomenal improvements in many of my patients and patients running through the clinic. It is absolutely possible to improve that, no doubt.
Okay, and with that, you've got tools. So I'm not sure if we're going there yet, but maybe we should talk about that. If you think about tools, because you need to probably stimulate the bone with energy, and then diet and medications. Where do we think about that?
The first thing to do is to risk stratify your patient to determine the fracture risk group. So looking at the number just on face value is a problem. So you need to put that into perspective. So, and if I can use the analogy with what we do with cholesterol and LDL, for example, you don't look at that number in isolation. You risk stratify that patient in the 4 groups, and you define where is your cardiovascular risk, your 10-year risk, and then you decide what to do with that value. And we've moved towards that strongly the last 5 years or so in our approach and management. So in the past, we literally look at the WHO classification where you fall and then make a decision. But so you incorporate your fracture risk. And so that is where there's been wonderful advancements in this field. And that is the FRAX score and the use of the FRAX score, where we basically use clinical risk factors to determine your 10-year fracture probability. And we can input the BMD value into this risk calculation. It's an online calculator, by the way, and it's free. And I would really advise our colleagues to use that more often, because you can use that risk calculator without a BMD, and it can already give you an excellent idea of fracture risk.
I think that's a very important point, or nice point to know that we can use it without putting in the DEXA scan result.
Absolutely. And I think we had our yearly NOFSAC Congress last week. And so the focus has really shifted to start by screening. That is the first step, by using the FRAX score to identify the higher risk patients, and then decide which deserve a bone mineral density. That's one way of deciding that. But so now there are different sort of criteria in these 3 risk groups. You have a low, a high, and very high. Those are the 3 risk groups, and there are different criteria to decide in which risk group a patient falls. It's more than the FRAX. So the FRAX score is valuable in helping us, but there are other things that you have to take into consideration, like a very high fracture risk. If you have, for example, a T-score of -3 or less, it places you immediately in the very high risk. If you had multiple previous fractures and so forth. So the point is just to risk stratify the patient using clinical risk factors and a few other things. FRAX score and BMD, will also help. And then from there on, one starts planning the intervention and the best treatment.
Well, it's actually moved quite a lot since we just thought osteoporosis, but it's now become a proper science.
Absolutely.
And I always say we sit here and we get pills, and I think that's one of the pills is we need to use that FRAX score more often.
Amazing.
Yeah.
So if you fall in the low risk group, obviously this is where I think most of our clientele might fall. What's the plan to keep that reservoir of bone mass that you've built up over time? You want to keep it for as long as possible. What lifestyle or dietary interventions, or just normal, things that you need to do to try and keep the bone as long as possible?
Maybe I can just start and share my model that I use. So I have what I call a pyramid model, how to approach this or management with different levels. So at the foundation is what I call lifestyle intervention. So there's your diet, your exercise, rest and recovery, and sleep, purpose, relationships, hormesis, things like that. That's in your foundational level. And I think that's valuable for every single patient. And the impact of those measures, which we can dissect a little bit as we go on, each of those interventions, but they are at the foundation. And I think I always explain to patients, well, before I go there, let me just run through the different levels. The next level is what I call training, conditioning, and entrainment. And I have a separate level to emphasize the importance of that conditioning and that training. Then we look at supplements, nutraceuticals. Then we look at hormone optimization. And then at the apex, pharmaceuticals. And I always explain to patients, you get so much more value when you use your pharmaceuticals and they are built on a solid foundation. So you need your side effects, just your benefit. So I believe by approaching this on these multiple levels and implementing all these levels, you get a cumulative benefit and it's just a way that I've developed and explaining to patients in a simple way how to approach that. So the foundational interventions would be like nutrition, and it's a big discussion on its own.
It's a religion.
Yeah, maybe we should just, while we've got nutrition, maybe just touch on two things there, because we get that, and always because we test vitamin D in our screening, we always go to calcium. So maybe we should just touch on those. Maybe calcium, what you tell your patients, where to get it, and then vitamin D. Do we get enough just from sun or food, or what do we do there? Maybe just in diet, those two, that we just get them a little bit of a handle on both those.
Yeah. So the first thing is calcium is really important. That is clear. And also calcium deficiency is more frequent than we think. If we do a calcium calculation on how much calcium do you get in your diet, many people are lacking the amount of calcium that they actually require on a daily basis. So realizing that is also important. And go and sit and do that calculation once, or see a dietitian to assist you with that. It could be really a revelation and just something that trickle you to make a few changes to your diet, because you shouldn't accept that your diet has enough calcium in, because it's often too little. I think the first principle there is dietary calcium is by far the best. So, and then also, if you look at the different dietary components, dairy is by far your best way of obtaining calcium. If you don't eat any dairy products, you're in trouble, and it's going to be really hard to get your daily calcium need in. So the bioavailability and a few other factors, around that, around dairy, makes it really a great way of getting calcium in. So I think that, and so supplementation. If you still fall short, it's a discussion more in the supplementation level, I would say. But
it's very individualized because of the diet, the difference in diet between people.
Definitely. Yeah. So you you risk stratify the patient before you would go there. If you have a more normal bone mineral density, focus on that. If you have really bad bones and you're really in trouble, you really want to make sure, and that's where you would supplement most likely, to just make sure you provide enough calcium to your bone. So you look at that risk benefit all the time.
And I think that's one of the pearls, is that you need dairy in your diet, because to get to, if I remember correctly, 1,000 milligrams or
1,200 milligrams
is a lot. I mean, if you think about an egg has got 40 milligrams of calcium. It's almost nothing. So you need 50 eggs. You almost can't get there. So per day, I mean, but a glass of milk has got 300 milligrams. So you can get there if you have enough dairy. But correct. I think the pearl here is, if you don't have dairy, go and look.
I'm actually thinking of it as, if you're going to calculate your own diet, you might fall short.
Yeah.
And then vitamin D, how do we think about that? Because that orchestrates is.
So, yeah,
I'd like to chip in and just say that we test everyone's vitamin D, and I think we had 2 people that was normal.
Yeah.
Most people for
almost everyone is under 21 deficient.
It's really a big challenge. And like calcium, vitamin D is crucial. And these two are really playing together, working together in harmony. And if we get to osteoporosis, let's just mention that quickly, and you use calcium and vitamin D as an intervention, as a treatment. The data is clearly showing that calcium alone does not benefit, but calcium plus vitamin D has data of BMD and fracture risk reduction benefits. So just to point, there is great data to in that, but vitamin D, we would use the level and guide us. I don't think supplementation for everyone is indicated. I think get your level and optimize then your level through diet, and preferably sun exposure and supplementation if needed.
Great. I'm happy with that. And then exercise is one of the other blocks.
Yeah.
So can you sit on a bike? Do you need to pick up weights? What is the... But you were just at the conference. What did they say? Well, must we...
Yeah, so impact, strength training and weight bearing impact is absolutely core. So you can do cardio. It's valuable. It's important, and it helps. Definitely for many other, overall mortality and benefits. But for bone specifically, you need strength training and you need weight-bearing impact training.
Yeah.
No doubt.
So you mentioned impact, and we're not talking about the impact when you're running. So we're more talking about actually putting tension on the tendon, on the bone, stimulating that mechanoreceptors to stimulate the bone.
That is that is resistance training.
Yeah.
So running is a form of impact training.
Okay.
But there are nuances on that, on how to add weight to that. Jumping is, and they also grade that as low impact, medium impact, high impact. So depending what you do. So walking is also per definition an impact, but it's a low impact. And there's a graded, a dose response benefit. So the more impact you apply, the more the benefits. So resistance is where you use bands and weights, maybe body weight or other weights. That's more categorized as resistance training. And that is really a game changer when it gets to muscle and bone improvement. So I think an important thing here is a myth that people has that walking, when I walk regularly or even run regularly, that is sufficient for my bone health and my muscle health. And I think So I often advise like 2/3 of your training should be resistance training, 1/3 form of cardio. So emphasizing the value of resistance training is actually an important thing that we do. And what we've seen is the phenomenal ability of the bone and muscle to adapt. So there's an amazing study, the Liftmore study in Australia, where Dr. Belinda Beck researched like really heavy weight training, resistance training in elderly patients. And it's amazing to see how the elderly women just work with heavy weights, and the gains and how it can be done safely has amazed me. So I think what we think that as we age, we cannot do, our bodies is not lost its adaptability and its ability to benefit from much more intensive training and even resistance training. And indeed, it is still able to respond to much more intensive training that we think and, create, stronger bones.
And again, I think that's a pearl that we get here is you need resistance training. We harp on about zone 2 training quite a lot and to build the base, but you need that resistance training. We actually pick it up with what we do, our strength testing of squats, push-ups, and grip strength in our assessment. What's quite interesting, in your base of your pyramid, you had sleep. And I never would have put it with osteoporosis. How do you fit that in, or how do you think about that?
So really, it's just one of those foundational things in recovery, I think, in an overall health is sleep. So I just put it there for every single condition. I haven't seen papers, looking at sleep and bone health. But even if you look at what's published these days on sleep, it is stunning on the value of sleep and the benefits of proper sleep quality and quantity. So I just put it there. And engage, but I can't say I don't have a real...
Well, I must say, with sleep, we know if you've got sleep apnea or sleep issues, you suppress your testosterone production through the LA axis. And that's a stimulus for bone health as well. So, I mean, there's definitely more than just regenerating. I mean, it's got a hormonal effect also on the bone.
Absolutely. I think there's a lot of physiological explanations or possibilities how sleep can benefit your bone health. And one can go into the whole discussion on inflammation and oxidative stress and sort of just regeneration and growth hormone and IGF-1 and so forth. So one can explain that very well.
Yeah. No, it's quite interesting. I like the way, I mean, we also use that pyramid always and say to people, but if your base is not built, you can't pull the pyramid higher on a low base. So it's exactly that. And then in your next step in your pyramid, you have
your conditioning.
It's basically training and conditioning. Okay. And I think I've just put it there to emphasize to patients the importance of creating that stimulus. Mm-hmm. So often we think taking our proteins, taking our calcium, getting our diet ready, is sufficient. But we need that stimulus and that conditioning and that sort of compounding effect. They should understand that compounding effect by the regular training over time is really important. And just to bring that home to the patients.
Mm-hmm. Yeah, I think people often just want to take something, but you need to put the effort in. And then once you've actually committed to doing the effort and you do it over time, the benefit is just enormous.
It's phenomenal. Yeah.
And then the next step, pharmaceuticals, HRT, They probably very close to each other, and we've had Dr. Marlena on here before about the hormone replacement therapy and how a whole generation was lost, people not getting, or females not getting hormones because of that the
Women's Health Initiative.
Yeah, WHI study. Is that a big drive, do you think, at the moment for the Osteoporosis Society as well? Or because in your pyramid you said pharmaceuticals and nutraceuticals and HRT.
Correct. So nutraceuticals was the next level, and then hormone optimization.
Okay.
And estrogen and all the estrogen, progesterone, and testosterone are the big players. But I think wider. Think thyroid, think insulin, think cortisol. That's part of hormone optimization. All these are players in bone health. And we don't always think of them and recognize that really. So just to keep us reminded that we should also think of that. But in practice, I mean, estrogen is the big player. And indeed, we have a strong focus on emphasizing and promoting and advising. And also in my reporting, I really want to put the attention on menopausal hormone therapy for the referral doctors and the patients to think about it, just consider it, do the risk stratification, and see if the patient will benefit, because it is a really, really important part of managing bone health.
Yeah. And then we get to the actual treatment of osteoporosis, or from a medicine point of view or medical point of view. And what's available, stepwise approach, how do you do it?
So we have a limited number of classes of medication available. And I think that's an important point to make, because it's a chronic condition. So patients who already has osteoporosis, they could even be in their 50s or early 60s. So they have a lifetime ahead, and we have a limited number of options. And each of these medication has also a limited sort of time frame in which we can prescribe them for the maximum benefits before we run into potential side effect risks. So that's the one important point about medication. And the second important point is that there are sort of also limitations in the efficacy of each one of these classes. So to stack these medication then, or let me rather say sequence them over a patient's life, is really important, and how to position them in that sequencing is really critical. And there's a lot of advances in that range. So, but what we have available in terms of classes is basically the anti-resorptive medication. So those who block the osteoclast in their working and so on. That includes like hormone therapy and related medication like serums and tibolone and so on. That's on the hormone side. In terms of pharma medication, it's basically the bisphosphonate class, and denosumab is the other main player there. Then on the bone building side, the osteoanabolic side, we have teriparatide, and we have romosozumab, a new player on the block. It's not available with us in South Africa yet at the moment, but so those are the main classes that we can prescribe.
Yeah, and as you said, some of them has got a limited time span that you can use, so it makes that pyramid of yours even more important.
Absolutely, and that is a very important point. And
it's so difficult to explain this to someone in their early 40s that they have to start planning for their bones at 65. But it is so important that piece between, and I mean, for cholesterol, for staying away from type 2 diabetes, that pocket of your life between 35 and 50 for me is like crucial for this. And it's like, that is the pyramid, because once you need the drugs, you're pretty much running into a risk of when you're going to get proper osteoporosis.
But the unfortunate bit of that age group, the 30 to 50. It's usually the time that you work the hardest, that you sleep yes, that you get your children and everything. And that's a time that you usually neglect yourself.
Absolutely.
And then you come in at 48. And then you pick up all the nonsense and all the problems. And then you need to work on it and try and get you back to a level where you function well.
But I think the 50 to 60 age range is still, I think, physiological. The body is still very responsive to, interventions, and it's really a golden period. I would say 40 to 50 even, I think, and I notice really awakening in many patients in that 40 to 50 age range that are already realizing, there are cracks in their health, showing up. And for me, it's a great opportunity to start this conversation, looking a little bit deeper and sort of have a long range plan, so long. But I think that time frame is really valuable and it's very important to start to take action.
And I think, again, we've talked a lot. I hope our colleagues have listened and the layman is getting enough out of this. But I think if the layman out there, if they can just realize how much can be done early with, people want to take stuff all the time, but you don't need to take stuff. You just need to move, improve your diet, improve your rest. Like the real basic stuff is actually the magic here.
That is true.
That's
yeah. So my little pull is that you need to speak to your children and make sure they get that outdoor exercise, build up that bone density as much as possible till the age of 20 to 30. That's what you need to do. Get as much as possible, and then we need to try and keep it, because you don't want to end up in a position where you 55, you need medication, but I can only take this one for 3 years and I need to take a break and what are we going to do after that? We want to try and avoid that. Yes, if you're already there, then there is things, there are things that you can do, but we want to avoid all these problems going forward. Because it's a silent disease, this is why we're having the podcast today, to tell people.
I think if you have risk factors, we've discussed a few of those things, but if there are any risk factors, check out your bone mineral density, and just make a start. I think if that is something that I could share with patients, that could initiate, just make that shift and awareness, of where you stand. If everything is fine, it's great. But if there are any significant risk factors, take action.
Marius, before we go, I want to ask, maybe you've got a nice success story of someone that you picked up early, basic interventions, and that they actually grew some bone. Have you seen lots lately? Because osteoporosis was like almost this morbid disease, and now it's something that we can actually do something about. So maybe you've got like a 48-year-old lady that was picked up and you did quite a few interventions or something like that. I don't know if you've maybe got something.
Yeah, I can't immediately think of a specific patient. I think I see usually the worst patients in person.
Yeah.
So patients that run through the institute that I do the reporting on,
okay.
I just see the numbers changing. So having a healthier patients. But I have actually seen one patient that is really T-scores in the below -3. It has improved to -2.5, and some of the values even less than that. So she was not willing to initiate medication, pharmacotherapy, and was really adamant. But she really went all out with lifestyle and with supplements, and we really packaged for a full package of everything. She saw a biokineticist, saw a dietitian, so, and I was actually amazed to see that level of improvement.
Great. We're going to link all your websites of your institute to our show notes. Maybe as a parting note is if someone out there remembers only one thing of this podcast about osteoporosis, what would you say? One thing that they should remember?
The importance of your bone and muscle organ in your overall health and in your future health is absolutely core and central and foundational.
Great.
I like that.
I learned a lot. I want to thank you for coming in. I hope our listeners and our colleagues out there learned a lot, and I can just say thank you again.
It was my privilege. Thank you.
Yeah, thanks for joining us.
Yeah. Thanks.
Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.